now we are really delighted to have with us Dr. Sabyasachi Sen. Though here it is afternoon or evening, but we want to say Dr. Sen, Professor Sen, a good morning because it is 6 a.m. in Washington. So welcome, Professor Sabyasachi Sen, in our platform where we are celebrating International Clinical Trial Day. So Dr. Sabyasachi Sen is the professor of medicine at George Washington School of Medicine and Health Science at Washington, D.C., one of the premier medical institute in US. So welcome, sir. We will learn from Professor Sen about stem cells, endothelium, and cardiovascular disease, and how we can translate regenerative research into clinical impact. So now this stage is yours. Over to Professor Sen.
Thank you, Dr. Samazdar. It's actually 7, thank God, and not 6 o'clock. but because it's 9.5 hours behind. But thank you so much for giving me the opportunity to talk about endothelium. Let me try to share my slides. I wonder, can you see it?
Yes, sir. Please make it full screen.
Is it full screen now?
I think it is not full screen because in some different modes it is showing. You can go to the display setting up. There is one display setting, I think.
Okay.
You can click on that. I think there you will get the option. Yeah, the swap. Yes, you can try that. Yes, now it's better. Yes, sir.
It's better? Okay.
Yes, yes.
Sorry, it seems to be listening to something here, but I don't know what it's listening to. But anyway, is this okay?
Yes, yes. Okay, sir.
Okay, good. Well, good morning, everyone, and thank you for giving me the opportunity for giving this talk on endothelium and adult stem cells as a biomarker, not only for regeneration, but also as a biomarker in clinical trials. My outline would be introducing endothelium and diabetes, or diabetes and endothelium, the role of endothelial progenitor cells, a little bit on stem and progenitor cells in general, and then its role in cardiometabolic diseases and its role as a biomarker, other modalities of endothelial function or indirect measurements that we usually do. So I'm going to touch upon on that at the end, near the end of the talk, and summary and conclusion. So as you all know, diabetes is a major disease across the world. Both India, United States, and China still are in the top 3 as nations in the world with diabetes. Both type 1 and type 2 and gestational diabetes are the main types of diabetes. This is a little bit dated slide, but it talks about 422 million adults having diabetes with 1.5 million diabetes-related deaths. So, but the crucial point in diabetes is the vascular diseases. There's many vascular complications from diabetes. So the reason we treat diabetes is not because of the sugar, but because of the cardiovascular disease or cardiovascular burden that diabetes presents. And the key to that is essentially the core lining of the blood vessel, which is the endothelium. So endothelium has good parts and the bad parts that impacts it. It's probably one of the largest organs in our body. that lines almost every blood vessel that we have because it needs to dilate and let the blood keep flowing and perfuse. So that includes nitric oxide, shear and stress, antioxidants. And I really want to stress antioxidant effect at a cellular level, regular exercise, and healthy diet. Healthy diet, when I say healthy diet, I would stress more so about non-artificial sweetener and non-processed food diet. On the other side, we have obviously anything that is anti of the green side, which is oxidative stress, hypertension, dyslipidemia is one of the main impacts on endothelium, smoking, and hyperglycemia. So the diabetes-related endothelial dysfunction, yes, there is effect of glucose, but then there is effects of lipids as well. It causes nitric oxide to go down, prostaglandins to reduce, and on the other side, it increases the inflammatory molecules as shown here with angiotensin 2 and COX-related factors. But you have to realize that the main function of vasodilatation and vasoconstriction is happening in the smooth muscle and not in the EC. And there is a balance between vasodilatation and vasoconstriction, which ultimately leads to the diameter of the blood vessel. So this is a little more in-depth into that. As I mentioned before, endothelium is the innermost lining. Then we have the SMC or smooth muscle layer. Then we have the fibroblast. There is, as I mentioned before, the nitric oxide, which is the critical element or function of the endothelial cells, comes from a critical amino acid called L-arginine, which is by action of endothelial nitric oxide synthase enzyme, produces nitric oxide, which then transfers in through the second channel through the GTP and GC, and via cyclic GMP causes vasodilatation in the smooth muscles. It has to diffuse down. Nitric oxide has to diffuse down from the endothelial cell layer to the smooth muscle layer to ultimately cause the vasodilatation. And of course, as I mentioned before, the reactive oxygen species is actually important, where if you have too much reactive oxygen species or ROS, that would impair the nitric oxide, leading to peroxynitrate, which does not lead to vasodilatation. So essentially, there is a physiological aspect to the nitric oxide, and then there is pathological conditions such as diabetes, rheumatoid arthritis, any inflammatory condition, which causes so-called the uncoupling of the nitric oxide. The hydrogen peroxide comes in. There is interplay of various genes such as NOXs and causes the endothelial dysfunction. Now, this actually is fairly pervasive, and that's why the endothelium needs to be regenerated at a very fast pace on a daily basis, and that's where the endothelial progenitor cells comes in. These are essentially tiny cells that looks like similar to the upper top part of the slide, which almost looks like a mononuclear cells from blood, but these are identified essentially for progenitor as CD34 positive cells, KDR meaning VEGF receptor 2 positive. So if you ask me, how do you identify these cells in blood or mononuclear population, these are essentially the markers. So you can flow cytometry sort these cells and subsequently study them based on as the need may be, and also to get as close as possible to the endothelium without actually tearing it off of some small vessel in your body. So these are essentially baby endothelial cells that are released from the marrow. The other cells that I'm not going to talk to you about, but are very critical in our body, and that does modify in diabetes, is the mesenchymal stromal cells. These look like the spindle-shaped cells. These are identified from CD73, 105, and 90 as far as the NIH guidelines. And the source could be any mesenchymal tissue, but these could be used as a biomarker as well. And as I mentioned, I'm not going to talk about these cells today, but these do get modified in diabetes as well. So going back to endothelial progenitor cells, as I said, these are the cell surface markers. These are mostly in the marrow, excuse me, and these move from the marrow into the peripheral blood in response to chemotactic factors that are released from a dying or diseased tissue. Only at any particular time, there's only 1% in the periphery, but in times of need, these actually can increase way up to 5 to 10%. So these cells are anti-apoptotic, pro-proliferative due to their secretory factors, but their prime function is migration. Without the migration, the cells will not be rescued, or damaged endothelium will not be rescued. And this so-called homing property is one of the critical functions. And this is sometimes mostly mediated by a very well-known chemotactic factor called SDF1 alpha, or stromal derived factor 1 alpha. And this is critically impaired in diabetes. So though one might actually have enough CD34 positive cells in the periphery, they're not reaching the site of injury or tissue damage. So as I said, these are the cells at day 0 if you take it out of a patient's blood. And these actually do make colonies by 14 days. And as I mentioned before, these are essentially, one needs to move from the marrow to the periphery, identified by these markers, and gradually from early circulating EPC or CECs, so-called become circulating EPCs. But as you can see, some of these marks continue to change, and ultimately the goal will be from 34 to 31, which is the progenitor marker is 34 and mature marker is 31. So they would gradually mature and migrate and then hopefully settle down. So this is essentially how it settles down to form the new endothelial monolayer. And as I said, the EPC gradually needs to mature over a period of time. The period of time is usually between 2 to 4 weeks, depending on the need and the number of progenitors one might have. Excuse me. So the EPCs in regeneration has been used over a period of time in various settings, particularly for cardiac regeneration, for heart failure, ischemia, and so on. And the number of cell therapy had increased dramatically across various universities in United States, Europe, and also Asia. We used some of these cells in our mouse model going back almost 15 years now, where we transplanted endothelial progenitor cells in an acute ischemic mouse model, where we ligated LAD, and these over a period of time did help to regenerate the left ventricle. As you can see on the left-hand side, we have the non-cell therapy heart, and on the right side, we have a cell therapy heart, and as with EPCs, and as you can see, there is well preservation of left ventricular muscle. This is a cross section across the left ventricle in the heart. And we showed that there's actually improvement of fractional shortening, which was as low as 19% to went up to almost 25%. Now you can say, well, this is only 6% improvement, but that 6% actually would change your NYHA classification from class 2 to class 3. And which means that a person can go up the stairs or even 3 flights or not. So there has been multiple human trials using EPCs over a period of time for ischemic regeneration. And as I said, in diabetes, these are the certain factors that impairs the endothelial function, and these have been used for various diseases such as diabetic retinopathy, peripheral vascular disease, and coronary artery disease. These are also the complications of diabetes, and this also summarizes the what I've also already mentioned to you about the migration number and functionality. So if one has to use these cells as a biomarker, one needs to look at the number, functionality, meaning the migration, which is actually, as I said, down-regulated, tube formation or colony formation, unit formation, and addition or inflammatory molecules by gene expression. So we, in our studies, specifically focus on diabetic kidney disease. And the reason being this particular complication is actually increasing dramatically, more so in non-Caucasian populations across the world. There's 1 in 3 patients with diabetes complications, and almost no patient that I see has a EGFR that is at 90 or above. So everybody is essentially at stage 2, if not stage 3 CKD. And this is primarily because of the effect of hyperglycemia, hyperdyslipidemia, and which ultimately leads to podocyte injury. I'm not going to talk a huge lot about the podocyte injury today, but remember, this is a podocytes are very key to maintenance of the called the glomerular function in diabetes. So anything that injures it, particularly the ROS, would lead to podocyte injury. So diabetes is a major cause of endothelial dysfunction and ischemia, and it's primarily leads to poor perfusion. Here is a picture of normal glomerulus on your left-hand side, and on your right-hand side, you have diabetic glomerular disease, where there's reduced podocyte number and glomerular basement membrane thickening. So we looked at various drugs that are known to have some beneficial effect in type 2 diabetes as far as CKD. These would be primarily the SGLT2s. We have various SGLT2s, and these are fairly, I would say, in our practice, we try to put it on almost all patients, because not only are they anti-hyperglycemic agents, but they also improve cardiovascular structure, cardiovascular function, renal function, perfusion in general. So we did a study using canagliflozin. These are, as you can remember, this drug was fairly first to come out, but this is a lot of what we saw was a class action. So we used a low dose. As you can see, we used only 100 as opposed to 300. We subsequently now are examining empagliflozin at a low dose, but let's go back to this study, which was 16-week study, very short study. So the beauty of using the stem cells is that you can use and keep your clinical trials at a short period, as opposed to several months or even years that you need to get a MACE outcome. So from our outcome measures, we took serum, we took the stem cells, where we looked at the migration, colony formation, and so on. And from the urine, we actually looked at the urine exosomes to discern podocyte inflammation. And we looked at specific podocyte-specific proteins such as podocalcin, nephrin, and Wilms tumor. I'm not going to talk about that today. Concentrate mostly on the blood-derived factors. So interleukin-6, as you can see, went down dramatically with canagliflozin, which is the inflammatory molecule. Migration assay improved quite dramatically within 16 weeks. Remember, this is only 16-week study. And CXCR4, which is actually very critical, as I mentioned, CXCR4 is the prime receptor that helps the cells to respond to SDF1 alpha. So the conclusion from this study is that it showed improvement even at a low dose with blood pressure, inflammatory molecules, and also certain genes, particularly the antioxidant genes. I know I didn't show you the gene expression studies here, but we did actually very recently another SGLT2, but this time we actually had a combination with DPP4 inhibitors. This was recently published in Stem Cells. This was a fairly short, small cohort study with only 4 or 5 patients in each group. But even there, you actually saw a reduction. So the blue bar is the control, red bar is the dapagliflozin, and green bar is the combination. And as you can see, in almost every group, there is improvement in the combination. And however, if you look at the red and the green bar, there's not a huge lot of difference. So dapagliflozin alone, without the SGLT, without the DPP4, is actually doing a lot of the good things that we would expect, such as CRP reduction and so on. Clearly, the lipids are better with the combination. If you go to the previous slide, clearly the glycemic control is better with the combination. If you look at the cell values, again, the migration fraction, which we got the statistically significant difference even at 16 weeks, using a low dose dapagliflozin with the low dose of saxagliptin, we do see a improvement both in DAPA and combination almost at a similar level. The colony formation unit didn't show a significant statistical difference, but the combination was slightly better. I wouldn't put a lot of stress on that, except the migration was clearly a better assay. CD34 numbers, again, were equivocal across the groups. Again, the conclusion from a low dose dapagliflozin and low dose saxagliptin, and as you can see, here is a pattern. The pattern is we have consistently done a low dose SGLT2 studies just to because these can be used not just in diabetes patients, but in non-diabetic patients with CKD and heart failure. So that's why we have kept doing this low dose study. In spite of pharmaceuticals coming back and telling me to do it in high dose, but we thought that you could actually get a lot of the positive effects even at a low dose of SGLT2. And clearly, the cellular measures, particularly migration, appears to be consistent and favorable with or without the combination with the DPP4. Moving on to the non-invasive studies, as I mentioned that I'm going to give a brief overview of these. We also look at certain tests such as flow-mediated dilatation. This is fairly well-established study. You use an ultrasound probe with a cuff where you inflate the pressure, and as you can see, you would expect about 11% improvement or increase in the diameter of the vessel. If you give nitroglycerin, which we don't, which a lot of laboratories don't, you can expect up to 18%. In our studies, the FMD was fairly reduced. It did improve a slight bit. Going to the next study, one can do a brachial artery ultrasound as well. And the last study that I would also talk about is a PAT, or peripheral artery tonometry. It's fairly easy to do. I think this should be incorporated in almost every clinical trial that we have. Non-expensive, gives a lot of information about reactive hyperemia, which is important and shows shear stress effect of enos. And another study that we have consistently done in all our clinical trials is pulse wave analysis and pulse wave velocity. This is a good study. This is not dependent on ultrasound and the person doing it. One would ideally, this is essentially looking at central pressure. as opposed to peripheral pressure. So we take a measurement at the femoral and the carotid, and then compare the pulse wave velocity and pulse wave analysis. This is one of our studies, very early on studies, where we just use saxagliptin. And as you can see, if you just take out the visit 2 between visit 1 and visit 3, there is obviously a progressive increase in the augmentation index, but with saxagliptin, it actually went up and then came down quite drastically, whereas the placebo, it actually stayed fairly high. So we concluded that this saxagliptin patients at least remained blood pressure was stable and not high and low with the so-called placebo, and as you know, that diabetes is a progressive disease. You don't want peaks and troughs. You want more a stable, low blood pressure. So augmentation index actually is a good measurement for it. So the conclusions from this talk one can take away is that our studies with using a cell in diabetic vascular disease monitoring using medications, low-dose medications, SGLT2, GLP-1, and so on, the cellular studies are missing. And I think the main take-home point I would say is we need more cell-based studies beyond serum-based studies that we have. These could minimize the time of our trials and gives a lot of information about individualized response to intervention. And thank you so much for listening to me and for inviting me to give this talk. Thank you.
Thank you, Professor Shen, for this enlightening talk. And I think this is a very important for all of us. We are very much naive to stem cell research because lots of other issues, lots of especially human stem cell research, regulatory issues. I think Professor Nandini Kumar is also there. I think he knows she was long time attached with ICMR, deputy director, and I think there are lot of hurdles with stem cell research in India. I think one question in my mind, if we talk about translating stem cell based research in different diseases, especially in the cardiovascular disease, as you are doing from bench side to bedside, in your setup, what are the biggest methodological or regulatory hurdles you have encountered in different trial design, especially if we talk about endpoints, durability of the effect, and also the immunological safety issues? So your take on that, sir.
Right. So let me take your last point. I mean, there's no immunological response because we are essentially taking the blood, getting the mononuclear cells, and examining the cells from there on, right? The progenitor cells. And as I mentioned that the only way to get to any form of information about endothelial health is to get the CD34 positive cells from the peripheral blood, or CD34 VEGF receptor 2 positive cells from the blood. The progenitor cells, as I said, carries a lot of information. I didn't go into gene expression studies, but that gives a lot of information about how the cell has responded in a short period of time. And you would be amazed that the stem cell genes change within 2 weeks. We have actually showed that if one exercises, enos increases within 2 weeks. And similarly, if you don't, it takes a little bit longer. By 6 weeks, it will fall back. So the supplyability of stem cells for future is actually amazing. It responds way faster than any mature cell out there in the human body. So one can regulate and one can follow a disease process much more intently and much more intimately as the process progresses. Your other concern about so-called regulatory hurdles, well, the only intervention we are doing is whatever the patient is taking. But the question is, what responds for you may not respond to another person who is from Hispanic origin or somebody from northern India versus southern India. We know that our genetic makeups are similar, but not same. One might respond to HGLT2 or DPP4 quite fantastically, but another part of India with other genetic makeup may not. So how does one get to individualized medicine? I think the cell-based assays are much more robust, gives more individualized access, and not just serum-based, which changes from day to day. And as far as regulatory hurdles, I haven't actually seen any regulatory hurdles. We try to keep our processes quite consistently across the various trials. We have, as I said, we have done DPP4, SGLT2, GLP-1, exercise, heart failure patients, and we have amassed a huge amount of data. And as I said, the most consistent result is beyond the CD34 number and gene expression is the migration study. Migration in stem cell or endothelial circulatory cell migration is a major problem, and that's why the blood vessels don't heal and the perfusion does not happen. Even if you transfuse endothelial progenitor cells in a diabetes, it hasn't worked until now because you're putting in good cells in a bad environment.
Yeah. So thank you, sir. So one question that has been asked by Dr. Moshumi De, what are the effect of progenitor cells in the cardiovascular medicines or therapeutics?
Right. So as I said, we have not yet figured out, well, there are a lot of emphasis on why the stem cells have not moved from bench to bedside. And the prime in cardiovascular realm or cardiovascular disease realm, and the prime reason is you're putting in stem cells which has bona fide regenerative property in a diseased environment. And they don't simply survive, and they undergo modification quite dramatically as soon as you put it in a toxic ROS mediated environment. So one needs to give it some protection. We boost up the antioxidant therapy. We put in various SOD2 or catalase, upregulate them using gene therapy. And then we have transplanted, and it has shown dramatic effect. Similarly, we have used p53 modification transiently, which gives some protection to the stem cells before you transfuse them. And these two therapies seems to have worked, and that work has been funded by American Heart for the last 10 years now in our laboratory. So with modification, stem cells has a role. Without modification, they have very little role in a disease process like diabetes. Even if you control the disease process, you can say, oh, I'm going to reduce his A1C from 10 to 7 and then transfuse. Doesn't work.
Yeah. So thank you. Thank you. We will take the last question from one physician member from API. He had mentioned like that, given the promise of endothelial stem cell therapies in improving vascular function, what clinical markers or imaging modalities would you recommend for tracking early benefit in patients with diabetic or atherosclerotic cardiovascular disease?
Excellent question. So as I was trying to allude to that the serum-based studies or imaging-based studies takes time. First of all, serum-based studies are very finicky. It changes and there's one inflammatory molecule level today, another level tomorrow. So it doesn't really give a very consistent result. Neither does it give a comparative result between one group of patients to another group. Whereas stem cells, as I was trying to say, is the meat of it, right? You're trying to discern endothelial dysfunction using everything else except the endothelium, which is crazy. Where is the endothelium? We talk about endothelial dysfunction. Was any of those studies to do with cells? Or was it looking at something else? It was looking at endothelial nitric oxide dilatation. But again, if you have to follow a disease, you should look at the cells rather than the serum. It's like trying to diagnose and follow a, let's say, thyroid cancer without a cell diagnosis. I don't think any endocrinologist would ever believe a BRAF mediated cell, so-called serum without any cells. Now, as you know, the entire BRAF diagnosis of thyroid cancer is based on cells. So why doesn't we do cell-mediated diagnosis in diabetic cardiovascular disease? So I think gives a very consistent, individualized response to a therapy, whether it's GLP. Now in the realm of GLP-1, it's even more critical. There's more studies coming out about long-term side effects of neuritis and so on and so forth. One needs to know who is it going to help and who is it going to harm. How do you know? This is probably the most non-invasive way of getting to the cells.
So thank you once again. Thank you very much for your all explanations. And I think we have Professor Proshun Chatterjee with us. Professor Proshun Chatterjee is a senior professor at the Department of Geriatric Medicine at AIIMS, and he's a very renowned clinician researcher from AIIMS. May I ask Professor Proshun Chatterjee, sir, please unmute yourself if you want to have a comment on.
Oh, thank you. No, I'm sorry. I joined late. As usual in AIIMS, it's always in clinic. Clinic to basic is little difficult, but always in clinic. No, I heard few last opinion of Dr. Sabyasachi. I think he's doing a great job. I just mentioned about I'm also working with mesenchymal therapy for frailty and dementia. So yeah, I'd love to get connected with you. I'm also sifting for the same work with from AIIMS to some other hospital for this purpose only, because I'm keen to explore the possibility as much we can, because frailty, dementia, sarcopenia are something we just say it is like age-related changes, nothing much can be done. That is the worst answer as a doctor we give to patient. What we don't understand, we say it is age-related changes.
Yes.
So so there I have lot of interest, and fortunately I'm getting good researcher to work with, and we have a good dedicated lab where we are planning to extract all this and work on it. Many disease has been explored, obviously, just like the thing you mentioned about heart failure in pressure sore and other things, but frailty, one trial of course has shown phase 2 trial has shown a lot of promise, Kratos trial I think. And then so we are working in the same model, and I'm also trying to connect with some condition media if we can improve the quality of cell, quality and quantity of cell. So
Yes.
I think today there are other speaker also, but so I'll not take much time from you. But if I get your mail ID, I can get connected with you and get your guidance.
Sure. It's SSEN1 at
a second, just
gwu.edu.
I think
I can
Sambo,
share.
you must be having.
I shall share that with you.
So I took a permission from you. Now I can take your mail ID and I can mail you, and I'll love to have and I think it is great that less participants, so there are a lot of interaction.
No, not less participants. We have more than 500
Oh,
delegates
okay.
with us. So
this is
for
the
faculty
faculty.
link only.
7 faculty.
So we have almost 526 participants
Okay.
who are watching us. So once again, we are really thankful to Professor Shen, because your lecture was so important for all of us, because in India, the stem cell research is not growing that much. We have various regulatory hurdles. We'll discuss in our panel discussion, maybe on that. We have Dr. Nandini Kumar, who is an ICMR, ex-ICMR DG. So thank you again, Dr. Shen. Now